This is a Japaigo hosted coffee chat, and I'll be speaking today with two of my remarkable colleagues from Nigeria and Lesotho. My name is Yemisi Ogundare, and I will be your host for today's coffee chat. And today we will be diving into conversations around TB, around tuberculosis. And so, just by way of a preamble, every year this moment reminds us that despite decades of progress in TB programming and TB HIV interventions, TB remains one of the leading infectious disease killers globally. And even more importantly, TB and HIV continue to collide in ways that disproportionately affect vulnerable populations, especially across Africa. And so this year's World TB Days theme highlights and puts a lot of emphasis on the need for urgency, the need for equity, the need for accountability, and moving beyond just commitments to real, measurable impact. And so today, we will turn the conversation slightly to talk around innovations, the assumptions around it, and integration
Are you seeing
of
me?
TBHI. And so I'm joined today by my colleagues and experts from, like I said earlier, from Nigeria and Lesotho, who bring in very rich field experiences from policy to community to implementation science to high level engagement, touching all the different angles of these conversations. And so they're the right people to bring in the room. They're the right people to have this chat with. And so I will be speaking. We're live. We'll have Dr. Victor from Japaigo, Nigeria, and we have Kemi from Japaigo, Lesotho. Kemi, let me give you a minute to introduce yourself and tell us a bit about you.
Thank you, Yemisi, and hello, everyone, wherever you are watching from. My name is Kemi Adeleke, and I serve as the country director, Japaigo Lesotho. Japaigo has been working in Lesotho in collaboration with the Ministry of Health for over a decade now, and we have been providing HIV prevention services. And recently, or currently, we also provide TB prevention, diagnosis, care, focusing more on community contact tracing, as well as TPT initiations among high risk population. I'm very excited to be bringing insight from our work here in Lesotho and to also be contributing to this very important topic as we celebrate World TB Day. Thank you, James.
Thank you so much, Kemi. Kemi, you work in Lesotho, and I know that. Thank you again, and welcome again, Victor. And Lesotho and Nigeria share, the same high burdens for TB, and so TB, like I said earlier, is a leading cause of death amongst people living in HIV because, again, of the connections between both. Co-infections are still significant in both countries. There have been tools, policies, innovations that have been deployed, right? And so, with the reductions in resources, with resources getting more constraints, and the need for us to do public health interventions differently and leverage on an integrated platform. Kemi, I'm going to start with you while we're settling with Victor. Could you throw more light on what you think and how you think integration can be better or results oriented in driving TB HIV interventions?
Absolutely, EMC. Integration on its own is an innovation. And in the country like ours in Lesotho, we do have innovation in the space of very solid and clear policy framework that really supports integration. But what I think that we should be doing now in the face of funding shifts is we need to relook at the way that we are investing in innovation. Innovation comes to life where there is investment. And I say investment in terms of costs. Innovation in itself is very cost effective, but it does need some upfront significant funding to make it happen. So, investment in primary healthcare setting, it's happening, but it needs to be strengthened. We need to bring, as we are bringing the services closer to the people, we need to make sure that the environment is ready to receive it. Primary health care is strengthened. We need to invest in our health workforce, continuous training, continuous development, continuous supportive supervision and mentorship, and just creating an enabling environment for innovation to really happen. So I believe that we really need to be looking at the costs. We need to be looking at strengthened collaboration, and we need to be looking at continued meaningful community engagement to bring the innovation to life.
Thank you so much, Kemi, for highlighting that. And I really love the fact that you touched on primary health care, because
Yeah.
that's the hub for an integrated care as we're looking TB, HIV integrations and all. And I'll come back to you while I go to Victor. And perhaps when I come back, you can touch more on how will integration work. You've mentioned funding, you've mentioned primary health care, you've mentioned health workforce, so, trainings, emphasizing that, supported supervision, emphasizing that. How better can we make integration work in practice? So while you're putting your thoughts together, I'll dive straight to Dr. Victor. Welcome, Dr. Victor. So I'm going to go straight
Thank
into your
you.
question. I'm going to go straight into your question, but just before you answer, it will be nice for you to take 30 seconds to introduce yourself and tell us where you work and your portfolio briefly as you dive into your question. And so your question for me is, there's been a lot of emphasis on tools in and innovations. And so what's the one assumption that people often get wrong about innovation versus the real world implementation in TB HIV integration?
Thank you very much, Yabisi. Can you hear me?
Very well.
Thank you so much for having me. My name is Victor. I'm Victor Adepoja. I work for Jepaigo in Nigeria. I work on our HIV and infectious disease work, whether it's viral hepatitis, tuberculosis, as well as other program areas. So happy to be here today and to answer your questions. I think for me, more often than not, we often misinterpret innovation uh, to translate automatically to impact. But that is one assumption that we always get wrong. The fact that we
Mhm.
have the innovation, the fact that we have all the tools, doesn't mean that those tools, those innovation, are automatically going to translate to impact. And how do I mean? If you look at the history of TB innovation, starting from 2011 when the WHO recommended gene expert machine for HIV, TB, co-infection, and individuals at risk of drug resistance, to 2020 where the WHO recommended universal molecular testing for TB. We've seen a lot of innovation near point of care test. We've seen innovation around non-sputum sample. For instance, you can now use swab test for tongue swab. You can use blood test for individuals PLHIV who have TB. You can take their blood sample, and use that to test for TB. So we've seen all this innovation over the years. We've seen current recent recommendation of the WHO to also use pool testing for TB, which is going to save us a lot of cost in terms of efficiency. But the question is, will all this innovation automatically, translate to impact? The question is no. Innovation alone is not enough. You need the systems, the structures around those innovations for it to work. For instance, when you diagnose a child who could not produce sputum, you're able to collect the tongue swab for TB testing. After diagnosing that child, how do you link that child to treatment? How do you pay for the transport of that child from that remote hard to reach area to the health facility where the drug will be taken? So these are all the systems and structures around innovation that will enable innovations to work, without which innovations itself become ineffective and useless. So I would say that is one assumption that we always get wrong. We feel like when we innovate, whether around diagnostics or around therapeutics, that automatically will help us to find people or place them on treatment or help us to eliminate tuberculosis. That is not always the case, but we need to build those systems, the infrastructures, the linkages that we need, and the enabling environment for those innovations to really translate to impact. I don't know if I have more time, but I can stop at that. Thank you.
Thank you very much, Dr. Victor. That was very spot on. Thank you. And I picked that. So innovation does not automatically translate to impact. So while innovation is good, we need structures, we need systems that it can run with. We need particularly simplified systems that, and just like Kemi said, so that at PHC primary healthcare level, they can be useful and they can then translate to impact. Policies, funding is also, very important. So thank you for highlighting those. I'll come back to you, particularly to hear around how community workers can take advantage of these innovations to improve care, how we can translate innovations into clear actions, into clear measurable impact. And so I like the scenarios you gave about the mother and the child. So we'll come back to you again to share with us on more insight as to how we can make innovations work. But before I come back to you, I'll go to Kemi. So Kemi, you started off really greatly and told us about how integration can work and the structures and the systems to which integration can work. So again, because like we said, the burdens for TB is largely impacted by Africa and low and middle income countries. So I'll come back to you in so how can integration work, particularly for HIV and TB integration? What are the tips, what are the ways that we can make integration practically work?
Thank you so much, MC. And you are very right when you say that it's a burden in Africa and as well in Lesotho as well. One of the characteristics of our beautiful country is that there's so many hard to reach areas, right? And this means that primary health care really needs to work. People, clients, patients should be able to get services within their community without worrying about transport costs and the cost, out of pocket cost that would get them there. So I really do want to emphasize on primary health care. We need to invest in it. We need to relook at it. It has to favor the people and be able to reach them where they really need to be reached. Another factor that I really want to emphasize, which is, sometimes we overlook, is that there is still some level, significant level of stigma in HIV and TB. People do not really want to be seen going for treatment in those two clinics. So we really need to look at the infrastructure in a way that, you can get all the services in one place. You don't need to go from one clinic, one room to the other to be able to get served for, these two this co-infection disease. So strengthening primary health care is something that I really do believe in, so that services, primary health care becomes a default. It becomes the way that we provide services. It becomes a default rather than a specialized kind of care. The providers there must be able to diagnose, or to be able to to pick up when it's necessary for referral, or be able to do the basic provide the basic HIV TB services. So they must have enough training. They must be capacitated to be able to provide those services and be able to then refer when it's needed. So yeah, I'm emphasizing on primary health care to remove the costs for the patient and to reduce loss to follow up, and as well making sure that the system, the structures within the community is also, making integration work. Thanks.
Thank you. Thank you so much, Kemi. And I hear you clearly. So integration fails when systems remain fragmented.
Yeah.
I mean, that's what I hear from you. So we need to find ways where we are making services integrated at the point of care, and people can get access to services that just like every other person. So it reduces opportunities and chances for stigma, and perhaps also investing more on social behavior change materials and research and implementation to ensure that, again, we reduce stigma. Thank you for highlighting those, and again for emphasizing primary health care. I'm going to come back to you, but before I go back to Victor as we try to wrap this coffee chat. So what are the 1, 2 barriers we must fix? What are your top priorities? I know there are a lot. You've talked about economic challenges for the community, transport cost. You've talked about health workers' support for supervision and all. What are the top 2 on your list that we need to prioritize that must work as we make integration to work? So
Is that for me?
Is
yes,
that for
that's for
me?
you, Kemi.
Oh
No,
yeah.
that's for
Okay.
Kemi. I'll come
So
back to you, Victor.
okay. Thanks, Yemisi. Absolutely. I mean, I top 2 for me will be number 1. I'm going back to fixing primary healthcare, investing in primary healthcare. Because we understand that we already know that it's a very cost-effective strategy, innovation, but we really need to put money, and and maybe going back to domestic financing, where we put money in making it work, right? So ensuring that the patient does not have to travel far. In our case, they are able to get the services right there within their community and only get referred when necessary. So investing in it, ensuring that there is money to bring the policy to life, right? And many of times it's not really that expensive. Well, yeah, I say that with some caution, but if we really look at it very well, closely, we find that we already have the system. We just really need to strengthen it with just minimal investment. So investing in primary healthcare is to ensure that it becomes a default, is number 1 for me. And number 2, I would also say continuous meaningful community engagement. Community is essential to integration. Ensuring that our community structures, like our community health workers, are really able to provide the adherence. You know how HIV, there were structures within the communities that supported adherence. We need to continue to strengthen that, and we need to continue to engage community structures, our community gatekeepers, our community chiefs, the entire community in both national and subnational level of discussions in TB HIV integration. So those will be the top two for me.
Thank you very much, Kemi. Thank you. So I'm going to move to Dr. Victor. So definitely you have highlighted it there. While we need resources, we can leverage resources from what is existing within the communities. We can have good, clear domestic resource mobilizations done. We can empower the healthcare workers with simple tools, with integrated tools to move integration forward. So thank you. Thank you, Kemi, for highlighting those. And also, Dr. Victor. So back on innovation, how can the healthcare workers, how do we mobilize healthcare workers to make integration work? So it leaves the policies and the beautiful technologies and architectures to real practice.
Yeah, thank you very much. Can you hear me?
Very well.
So thank you very much. I think I like the role of health workers, especially community health workers. I think they have a very significant roles to play in making innovations to work, and they've played a very significant role in a country like Nigeria. When you look at 2020, when we have COVID, where most African countries, low middle income countries, high TB countries, TB body country reported decline in case notification. You notice that Nigeria instead reported an increase in case notification from what we have been static for many years, around 100,000 to about 140,000 plus in the COVID era. And the community healthcare worker play a major role in these dynamics, in this shift. When people could not come out, they're able to go to the community. They support patients who are on treatment to be able to complete their medication. They are closer to the people. They can go to many places that you and I cannot go to. How to reach community, riverine area. That is to highlight the role that community healthcare workers do play in innovation. And I do think that as we look forward into the future of TB elimination, community healthcare worker play a very significant role, to play in the future of elimination of TB. For instance, we know now that case finding is no longer a big problem. Nigeria has moved from, for instance, 100,000 hand notification to about 400,000 over the last 3 to 4 years. But the question now is, how do we retain these people? How do we make sure that we don't lose them, after we have found them, after we have done a lot of case finding, the community health worker has helped us to be able to identify them. How do we make sure that we don't lose them? Because if we lose them, then we stand the risk of treatment failure in the making or resistance in the future. So I think that's the big questions as we look forward to the future of elimination. Nigeria now, going from about 27% of treatment coverage, is up to about 70-80% of coverage. But as quantity increases, quality will become an issue. And that's where I think healthcare worker, community health worker can help us in case holding, to make sure that they visit them, they call them, they counsel patients. Adherence counseling is going to be very key. And we need to train them. We also need to pay them very well, because we are talking about integration. We are saying that community health workers should not just go to the community and screen for TB alone, but also screen for HIV, or even hepatitis, or even any other communicable diseases. And that's what we have seen demonstrated by the current Global Fund efforts in Nigeria, where community health workers are doing integrated training, not just screening for TB alone, but also screening for other things. These are all the ways I think we need to build the capacity of or community health workers to be able to help us to really deploy this innovation, effectively, at community level. But I think apart from capacity, we also need to make sure we remunerate them very well, because they need to be motivated to do all this volume of work. You want them to do this and that, but you also need to make sure that you pay them and compensate them adequately to be able to effectively do this. So I think these are all areas I think we can use them. Integrated screening, integrated referral system is one concrete area I think we can deploy them. We need to build a capacity to be able to do more than what they are currently doing. We also need to build a capacity in some of these innovations that is, patient-centered innovation that is bringing the services, to the patient, closer to the patient in the community, whether it's at the level of screening or diagnostics or referral, or even retention and care. These are all a cascade of care, because any innovation that you don't align with a patient pathway is not going to work. So as we deploy this innovation, we need to be able to align them to the patient pathway, whether it's the screening pathway or diagnostic pathway or treatment pathway or even follow-up. So we need to be able to align them. Otherwise, they become very weak and ineffective. There are so many ways that community health worker can be. And the story of Nigeria or any other country that make tremendous progress in TB case finding cannot be told without talking about the community health workers. Private sector engagement is also very key. Community engagement is very key. Educating the community, religious ruler and traditional rulers, to be able to, remove stigma and see TB as something like any other diseases. So it's also very key, and community health workers can play a role to educate the community, to dispel rumors, to dispel misconception about TB, and make sure that they build the confidence of the community to come and access care, and not
Right.
just accessing care, follow up, and making sure that they are retained in care. Thank you.
Thank you so much, Dr. Victor, for highlighting that. I hear access. I hear, capacitating the healthcare workers, keeping them motivated, building the capacity on the tools, on the innovative tools that we need. And it just highlights the fact that innovation does not save lives. Implementation of them is what does. So
Yeah.
we need to ensure that it's as much as we are advocating for innovation, we also advocate to ensure that they are properly used and it then is well implemented and it saves lives. We have just very few more minutes to go, and there are a few questions on the chat box, and I would encourage for everyone that's joining us today, feel free to ask your questions. We will continue to talk about this subsequently and respond to them. There's a question about limitations in drugs, in medicine availability for TB, particularly in Africa. And so one of our audience participants asking what are the roles or what is the information around regional manufacturing and production around Africa. We representing Western, Eastern, Africa on this platform. So you or Kemi, do you want to throw light on that? And really, maybe we take that for 1 minute, and then we take another question from the chat box for another minute before we end. Victor, you want to chime in on that?
Yeah, I think that was a very good question, and for us in Nigeria, the government of Nigeria is really doing a lot of work to make sure that local manufacturing become not just a dream, but a reality. We've seen some progress around manufacturing of some basic products in the country, including also diagnostic kits, and I agree that regional manufacturing and some of this conversation around local manufacturing, TB also, play a very major role in around that conversation, whether it's the TB medicine or even the preventive medicine, or even some of the diagnostic kits that we're using. For instance, we know we have point of care testing like TB Lamb for PLHIV, which is point of care, like it's like a rapid test, which are some of the things that are like the quick wins or the low agri foods that the country can consider as the advanced conversation and investment towards independence and journey to self-reliance with respect to local manufacturing. So I see an opportunity around not just TB product, but some other products, whether it's the HIV kit. We know that every TB patient or presumptive patient, you need to screen them for HIV as well. So I see
Okay.
opportunity in manufacturing of rapid diagnostic kit for HIV, or even some of the. So we can start small. I believe we might not be able to manufacture the therapeutics now, but there are other things that we can manufacture
That we can
that can help us.
manufacture.
Yeah, thank you.
Thank you so much, Dr. Victor. Work short with time. 30 seconds, Kemi. What are some of your closing thoughts? Or perhaps one TB innovation you're most excited about in 30 seconds?
10 seconds. All right, thanks, MCC. I mean, all the the innovations that we have right now are great, absolutely. And I just want to say that I agree that we really need to start looking at, in our case in Southern Africa, regional manufacturing, and so that these innovations come closer to us.
Oh,
Um, my
thank you.
closing thoughts will be innovations, innovations plus collaboration plus meaningful community engagement
Thank you.
equals transformative healthcare services. Thank
Thank you so much, Kemi and Victor. Sorry we're
you.
out of time, but thank you so much for joining this conversation, everyone. Let's continue to challenge assumptions, strengthen implementation systems at community level, ensure that innovation translates to real impact where it matters the most, which is the community and the health facilities. Let's continue to push the work forward and make TB a case of the past, as especially for low middle income countries. Thank you so much for joining us, everyone. This has been great, and this has been brought to you by Japaigo. And we look forward to you joining us for subsequent sessions tomorrow and for other coffee chats. Have a great rest of the day, everyone. Bye.
Thank you.